I'm John Saltzman, Director of Endoscopy at the Brigham and Women's Hospital and Associate Editor of GIE. I'm speaking today with Dr. Srinadh Komanduri, who's at the Feinberg School of Medicine, Northwestern University, about his paper on radiofrequency ablation for refractory gastric vascular ectasia. Tell us about the background for this study.
So we took a cohort of patients prospectively in an open-label study of 21 patients who were refractory to a standard of care of argon plasma coagulation, and we tested this novel technology of radiofrequency ablation, specifically looking at patients who are transfusion-dependent with anemia or GI blood loss, and to assess their final outcome of transfusion dependency after treatment.
And so tell me a little bit about the patients you included in this study.
So the patients we selected, the GAVE patients in general are a difficult population because they tend to occur in patients with cirrhosis or autoimmune disease. Specifically in patients with cirrhosis, this can overlap with portal hypertensive gastropathy, and the distinction needs to be made clear. As a result, we took patients with purely antral dominant gastric antral vascular ectasia without severe portal hypertensive gastropathy.
And tell us what you found.
So in these patients, they had a mean number of prior APC sessions of 3, which in the previous literature, anywhere from 2 to 4 sessions were thought to be adequate to see a response. So patients who were quote-unquote refractory after 3 treatments with argon plasma coagulation were enrolled prospectively and subsequently underwent radiofrequency ablation with the focal Halo Ultra ablation device. And we found that out of these 21 patients, 19 out of 21 actually had technical success, meaning that the procedure could be performed, and 18 out of 21 actually had clinical success, meaning they had no transfusion requirement over the following 6 months. The mean number of transfusions prior to therapy for 6-month period were 8 units of blood.
And are there any special technical considerations with this device? Tell us a little more about the device and how you use it.
Yeah, so it's obviously a little bit different than a standard through-the-scope treatment device. The Halo ablation catheters are attached on top of the endoscope or to the endoscope with a fitting cap. One of the technical issues here is the paddle itself has to be rotated, being positioned into the stomach into the proper position. So the initial issue is we have to remove the scope at least once to change the position of the paddle from a 5 o'clock position maybe to a 7 o'clock position to cover the whole base of the area of GAVE to be treated.
Is there any difficulty in intubating the esophagus with this device or coming out from the GE junction?
Since the device actually protrudes off the end of the endoscope almost like a baseball cap, you have to be a little bit careful. We do this routinely in Barrett's esophagus, and I think with experience it becomes very straightforward in just how you negotiate it, and at times actually a little more simpler because you have this device to actually guide you through even difficult oropharynx. But just a technical care needs to be taken, but otherwise nothing significant in terms of severe complications if done properly.
So with this promising experience that you have, do you think this should be in refractory patients, or should it be our primary therapy in patients with GAV?
I think currently this is meant for patients who are refractory to APC, and I think part of that is just the practicality. This is a significant additional cost at this point. Also, it's not in everyone's endoscopic toolbox to date. It's not something that everyone who treats GI bleeding would have available to them. So I think the standard of care still remains a trial of APC, but I think this proves that this is an effective therapy for refractory GAVE and something that we should consider in those patients.
Well, great. Thank you for talking with us today, Srinadh.
Thank you very much.